The question was, if somebody's voices are not particularly disturbing or distressing or intrusive, would one up the dose of the medicine? And my answer is no. I mean, what we're here to do is to help people feel better and do better, get on well with their lives. And if the voices are not interfering with how you feel or how you function, then there's no particular need to try and achieve perfection by eradicating them, and in the process you might very well cause a lot of side effects. The other thing which is important to know, and many psychiatrists I think don't realize this, is that auditory hallucinations are very common in the population, period, amongst people who have no mental illness at all. So maybe 1% or so of the population suffers from a psychotic illness. Certainly 6, 7, 8% of the population hear voices or other forms of auditory hallucinations quite regularly, and they don't have a serious mental illness. So in children it's quite common that they will hear voices. So I've talked to elementary school classes about psychiatric illness, and several kids have held their hands up and said, I've heard voices like that. And I think it does happen more in children and maybe gets less common as they grow up. It happens in college-age kids all the time. Musicians hear music in their heads all the time. Bereaved partners hear their partner's voice frequently. So one certainly shouldn't jump to the conclusion that if somebody's hearing voices or something like that, that he or she has a psychosis, or that it's necessarily a bad thing. A young man that I talked about earlier who had very severe panicky fears of being tortured and kidnapped and killed when he was in the depressive phase of his illness, was hearing voices all the time talking about that. And when he got into the manic phase, they were very pleasant voices. He's now in the middle. He's not too depressed and he's not too elevated, but he's still hearing the voices. So I said to him, well, would it be all right if we didn't really bother to try and eradicate those altogether? Would you be able to tolerate it if those voices just went on in a sort of background noise kind of way? And he's, oh yeah, that'd be fine. And he's working and skiing and rock climbing and going back to school, leading a very full life. So that's the answer to your question. No, I think that it would be a mistake to push medicines to the point that you try and get rid of voices altogether, because you're probably not going to succeed anyway without causing side effects. What I was leading up to in talking about Emil Kraepelin defining schizophrenia as this illness that had this progressive downhill course, he was actually completely wrong. And one of the pieces of research that I did fairly early on in my career was I dug out all of the outcome studies in schizophrenia through the 20th century that I could find, and sort of amassed them all together in what's called a meta-analysis to look at what the actual recovery rate has been throughout the 20th century from schizophrenia. And the interesting finding was that there always has been a very substantial complete recovery rate from schizophrenia. So people come in the door, they get into a cohort of subjects or patients that are followed for anywhere from 2 years to 40 years. And what's the outcome at the end of that period of time? In fact, in every period of the 20th century, except the Great Depression, 20% of those people recovered completely from the illness and returned to their normal pre-illness state of functioning and absence of symptoms. That was on medicines after the medicines were introduced, but in the first half of the century, it was just the same, off medicines. Before there were any medicines to be off, people still recovered 20% of the time, except during the Great Depression. Of course, during the Great Depression, the asylums sort of filled with people who couldn't leave because there wasn't any work for them to do, essentially. So there was much more crowded asylums, and people didn't get out in the same kind of way they have at other phases in the 20th century, any other periods. In addition to that complete recovery rate of 20%, there's an additional 20% who recover, either before there were medicines or after, so that they can function independently in the community, earn a living, and not present problems to the community, so that they're essentially, the behavior is well controlled and their functioning is adequate. And so this has always been a feature of the illness, that there's an illness where the natural history is one of recovery for a certain proportion. And why does it happen for some and not others? It's because it's not schizophrenia, it's, as Eugen Bleuler called it, it's the schizophrenias, and there's probably any number of different conditions in there. What's very clear is that an episode of bipolar disorder makes it likelier that if you have one, it makes it likely the next one will come sooner. So each one you get tends to lead to a shortening of the period of recovery. However, if you can prevent the episodes with treatment, then that in itself leads to recovery. So you're preventing the episodes, they get further apart, and so plenty of people become completely stabilized and fully functional in treatment for bipolar disorder. What we call it, multiple personality, is not a feature of schizophrenia. It's completely false concept, and so when people throw around the words like the Denver Broncos are really schizophrenic this season, they they either win really well or they fail really badly. That's a completely false use of the term schizophrenic. So the question is about cognitive behavioral therapy in schizophrenia, or in psychosis in general. So just let me talk about that a little bit. This is a field of intervention in schizophrenia, which is developed initially in Britain, and then developed quite a bit more in Australia, and finally was introduced here in the United States. And there's lots of research to show that the opposite to what we were taught when we were getting into psychiatry all those years ago. We were taught you can't persuade somebody out of his or her delusions, don't even try it. Well, what the British psychologists who moved into this area decided to do was to see if you could just get people to begin to examine the evidence on which delusions were based. So it would be, for example, this lady gets on the bus and somebody moves his or her seat on the bus, and so she thinks it's because she smells badly. And so it's reinforcing the delusion that she smells. But then the psychologist might say, well, now let's think, were there any other possible reasons that she might have moved? And so just by gently having people re-examine their delusions in a different way, for example, is a component of cognitive behavioral therapy. Another is developing coping strategies to deal better with your hallucinations or delusions so they don't distress you as much. For example, if you always get bad hallucinations when you're on your own, then you might try to be in the company of other people more. Or if you hum, in fact, you can't hear auditory hallucinations anymore, usually because you're using your vocal cords, and that makes it impossible to hear the voices. Or if you sing for the same reason, you might squelch the voices. So all of these ways of developing strategies or developing new ways of looking at your hallucinations so you have a decreased level of distress from the symptom, that's proven to be a very effective intervention. And your question was, how do you find someone who does it? Well, even in England where it started, there aren't that many practitioners, but it's more common that psychologists will be trained in this method, and of course it's only been in fairly recent years that American psychologists have been trained to do cognitive behavioral therapy for psychosis. That many of them, though, have been trained to do cognitive behavioral therapy for depression and panic disorder and anxiety and so on. ECT is in some cases a life-saving procedure, primarily for people with severe depression that doesn't respond to treatment with the standard approaches, which would be antidepressants. Likewise, in the severe depression in bipolar disorder can be treated with ECT, and interestingly, it's also effective in mania. If somebody's manic and they get ECT, then they are likely to revert back towards a stable mood. So it's fallen out of favor because the medications that are being introduced are really very effective in these conditions. And so it's really only valuable for people who are very ill and haven't responded to the standard treatments. We probably refer 2 or 3 people a year out of a caseload of well over 100 for ECT each year. And the young man I told you about who was absolutely panicked because he was going to be tortured and chopped up and killed, and it went on day after day after day and didn't respond to medications. He was referred for ECT, and that helped him get better to the point that then the medicines that we're prescribing were able to keep him stable. There is very marked regional variation in the use of ECT. We had a patient here 15 years ago in Boulder who had very severe catatonic schizophrenia, and when he got ECT, it brought him out of his absolutely paralytic state. It was effective. Unfortunately, he decided to take off to California, and he was in California, and clearly he was just as disabled again, unable to move at all. He couldn't find, nobody could find any place that would give him ECT, so his parents eventually put him in a van, brought him back to Denver, and he got ECT here and he got better. And that really saved his life. The question was, could I talk about the negative symptoms of schizophrenia? And I should have done that much earlier. So what we're talking about are, in psychosis, are really 4 sets of symptoms. The positive symptoms, hallucinations, delusions, agitation, etc. The negative symptoms, which are the things that should be there that aren't. The positive symptoms are things that are there that shouldn't be. Negative symptoms are things that should be there that aren't. So it's the absence of certain aspects of just being human in the world that are not present for many people with psychotic illness. One of them is the absence of a normal display of emotion in the face or experience of emotion. And we call that a flattened affect. The affect is sort of the objective, observable aspect of mood. Or an inappropriate affect, but that's somewhat different. An absence of an interest in doing things or moving ahead with your life, or really going to school or reading or just being involved in normal day-to-day activities. That would be lack of motivation. Lack of a spontaneous flow of thoughts or ideas, what we call poverty of ideas. And finally, lack of an interest in interacting with other people, or social withdrawal. A person just stays in his room, might reverse day and night, only get up in the night when everybody else is in bed, and stay in his room and sleep during the daytime just to avoid social interaction. How do you distinguish that from depression? It's hard, because a flattened affect can look very similar to a depressed affect. Social withdrawal can happen in depression. Lack of motivation can happen in depression. And also people can end up speaking very little in depression. So really you can't distinguish it very easily cross-sectionally. If you just look at the person today. What you have to do is look at it in the context of the rest of the person, in the course of the symptoms, and in the surrounding symptoms. So if the person is in tears for much of the day, if the person is suicidal, if the person has negative content to his or her hallucinations or delusions, then that would push you into thinking these symptoms in fact are just part of this severe depression. If, on the other hand, it's someone who has had an episode of psychosis with rather neutral content, and now this is a very long, ongoing, been going on for a couple of years, state of lack of these normal aspects of being a human in society, that makes it more likely that you're looking at the negative symptoms of often schizophrenia, but also other psychotic illnesses. And finally, did I mention that the fourth symptom set are cognitive symptoms, cognitive deficits, and people with schizophrenia, particularly if they have a lot of negative symptoms, can develop problems with attention, with what's called working memory, problems with speed of mental functioning, and these sorts of cognitive symptoms can really interfere with a person's capacity to function. I think that we don't need to think about these psychotic disorders that we've been talking about today as categories. I think we're moving in the next 10 years towards thinking about the psychoses more in terms of dimensions, and I've talked about these four symptom sets, and let's call those the dimensions, plus affective symptoms would be another dimension. Because in fact, when we're presented with a person with a disorder like this, and we're trying to think how are we going to treat the person, well, we'll look to see if that dimension of, say, depression is important, and we'll think about treating that. Or can we see an affective dimension where the person's got opposite poles? Does the person have a lot of positive symptoms? So we'd be thinking about the antipsychotic medicines for positive symptoms. We'd be thinking about the mood stabilizers if they're affective symptoms. If somebody's got cognitive symptoms, we might be thinking about cognitive remediation. And then we might be thinking about antidepressants. So that's how we actually treat people. And to tell you the honest truth, I think the diagnosis then often flows from which dimensions we thought were important and which medicines we prescribed. Inheritance is an important factor. That if schizophrenia runs in your family, then there's an increased chance that you will develop schizophrenia, but it's not an overwhelming factor. If you have a first-degree relative with schizophrenia, your chance of getting it increases from about 1 in 100 to 1 in 10. And if you have two identical twins with exactly the same genetic makeup, the risk that the second twin will get schizophrenia if the first one does is only about 50%. So it clearly is not the whole story. So what's the rest of the story? Well, the big factors are intrauterine injury or obstetric complications at the time of birth. So maternal infections to a limited degree, maybe even vitamin D, maternal vitamin D deficiency perhaps will turn out to be important. But it's more importantly are causes of hypoxia or low oxygen, oxygen deprivation of the fetus due to placental problems or cord around the neck or prolonged labor, and maternal diabetes, in fact, turns out to be a very, very important factor in increasing the risk of that child growing up to develop schizophrenia. Then there are some other odd ones that turn out to be very important because they're just such common factors that affect a lot of people. And one of them, strangely enough, is being born and growing up in a city. And there's got to be a mediating factor there, and who knows what it might turn out to be. Was it lead in gasoline in the days when there was lead in gasoline, or is it maternal vitamin D deficiency due to being in a grey, not so sunny setting? So those are some of the big factors we're talking about. Talking about both the genetic constitution the person's born with and their exposure to certain environmental factors, and maybe also some postnatal traumas like high fevers in infants and so on can add to the risk of person getting schizophrenia. What does protect to a certain extent against schizophrenia are female hormones, and this is why women have a later onset probably than men for schizophrenia, so about 5 years later or so in the early years, but also there's quite a peak in the incidence of schizophrenia in women after the menopause. So we think about schizophrenia as being a disease of young people after puberty, but in fact in women the prevalence catches up eventually with men with this post-menopausal peak. And we not uncommonly see, seems to me, particularly paranoid schizophrenia in women has a peak at that point. Many people that we see with bipolar disorder developed it. You can track back the first depressive episode, say, to quite an early age, maybe even before puberty. Many of the first episodes are going to happen when the person's in college. But also I've seen many people who didn't develop the illness until late in life, and it was often after some kind of trauma to the brain. We had one person who developed it after falling off a horse and hitting his head, another person who suffered a water ski injury with a blow to the head. So, and other people maybe suffer alcoholic brain injury and then are more likely to get bipolar disorder on top of that. So it's much more spread out. We're just developing a forum which is going to be for an online forum which is going to be for essentially discussion and psychoeducation for people who are our clients and their family members. But what we put up on the web, on our website, www.coloradorecovery.com, is about 600 pages of information on all of these illnesses and questions that families and clients often ask. So if you go and click on forum and just start looking at that site, you could spend a week on it probably. Then there are other components of that website which are about schizophrenia, psychiatric rehabilitation, bipolar disorder, stigma, you name it. There's a whole lot of stuff up there that with some references and so on. Well, thank you very much for your attention, and I hope it was helpful to some of you in some ways.